Good afternoon all, this is the Royal Cornwall Hospital coming to you live with our webinar From Puff to Powder. We'll be bringing you advice and guidance on inhaler techniques, talking about the environmental impacts of inhalers and discussing how to switch from MDIs to DPIs, but asking the important question first. Is it always the right thing to do for our patients? Let's find out. Shortly you'll meet your host, Dr. Kawita Schur, General Practitioner, and Jill Leyshon, Respiratory Clinical Nurse Specialist. But before I hand you over to them, please put any comments or questions you have in the chat and we'll pick them up at the end of the session. So until then, I think it's time to talk inhalers. Ladies, it's over to you.
Thanks, Roz. Over the next 45 minutes, we'll be looking at why we need to change our inhaler prescribing habits and how to go about it. I will start by talking about the impact on the planet, and then Jill will take over to talk about optimising patient care before we share some practical tips about how to get started. It's easy to feel overwhelmed with such a multitude of problems to tackle. How do I begin? How do I make a difference? But remember that we are not alone, and together we can bring about massive change. Today we'll be talking about one area where we can make a difference, and we will try to leave you with a feeling of hope that there is something that you can do, something that's better for you and for the planet. I feel that it's empowering to know that we can make more of a difference by using our professional capacity than we can as individuals. Simple changes to our practice, including our prescribing, will make a huge difference in helping to reduce the carbon footprint of the NHS. We are already beginning to see the impacts of a changing climate on our health. This will increase as we hit higher temperatures. The Marmot Review, Fairer Society, Healthy Lives, reminds us that more vulnerable groups will be disproportionately affected. On our current trajectory, the World Bank predicts that by 2030, climate change will have reversed public health gains, putting 100 million people back into poverty and causing at least an additional 250,000 deaths annually. Whether we are doctors, nurses or pharmacists, we have had do no harm embedded into us from our first days of training. Patient safety, as defined by the WHO, is the coordinated efforts to prevent harm caused by the process of healthcare itself from occurring to patients. This illustration shows healthcare's climate footprint. So in the work that we do, striving to improve the health of our patients, we are at the same time adding to the problem. When I first realised this, it struck me that we have a responsibility to change our practice and a duty of care to do so. But don't despair, we are not alone, and together we can bring about massive change. Here you can see the carbon hotspots of the NHS healthcare subsectors. Being a GP and looking from a primary care perspective, I found it striking how pharmaceuticals represent the largest carbon hotspot, with metered dose inhalers, MDIs, having their own carbon hotspot. This is why I chose to begin my journey into the quest for greener inhalers. Metered dose inhalers contribute 3% to the total NHS carbon footprint. 23% of the NHS's total carbon footprint comes from primary care, with 13% of this being inhaler related, compared to 39% on running the practice and 48% on pharmaceuticals and chemicals. This slide looks at the NHS plan of how to achieve net zero. Though it's difficult to see all of the detail, the red dotted line at the top, projection 1, explains how carbon emissions would increase if we did nothing. The wedges underneath represent predictions of how different interventions may help the NHS to achieve net zero. Low carbon inhalers are in the blue section. So what is the problem with MDIs? The propellants within the devices, hydrofluorocarbons, are powerful greenhouse gases. This graph demonstrates just how much more powerful they are when compared with carbon dioxide, the most abundant greenhouse gas. Many of you will have seen this representation comparing the environmental impact of metered dose and dry powder inhalers. 88% of the greenhouse gas of Ventolin Evohaler is released during inhaler use and disposal, with the remaining 12% being released during manufacturing. Regarding disposal, inhalers should always be returned to pharmacies for recycling or incineration to reduce their emissions at that point. There are lower volume MDIs than the Evohaler, for example, Salamol, and though these have a higher environmental impact than the DPI equivalents, they should be considered for patients who are not able to take a dry powder inhaler. But Ventolin Evohaler is half the price of Ventolin Accuhaler at £1.50 compared to £3, isn't it? Let's look more closely. An audit carried out by NHS Grampian in 2017 found that on average 48% of MDI doses are wasted, compared with 27% of DPI doses. Ventolin Evohaler has no dose counter and may explain part of the reason for this. An individual may require more prescriptions per year as a result. In 2003, research showed that 70% of people make an error when using an MDI, compared with 50% using the DPIs available at that time. This error rate is likely to have reduced significantly for the dry powder inhalers with the advent of newer, more easy to use devices, though the research has not been repeated. Technique error results in poorer disease control, increased number of exacerbations, and an increase in use of medical services. So is the financial cost of using Evohaler actually higher than that of Accuhaler? Regardless of these additional considerations, in 2019, Wilkinson et al. Concluded that switching to DPIs would result in large carbon savings and can be achieved alongside reduced drug costs by using less expensive brands. Our local formularies will help to guide you to make these choices. Janssen et al. Looked at the annual carbon footprint in kilograms of CO2 emissions per patient using specific combinations of MDIs and DPIs, shown in this bar chart. To the right of the chart are some examples of individual actions which lead to reduced carbon footprint. The two bars on the left show DPI-only combinations, contributing 17 kilograms of CO2 emissions annually. The next two bars show a DPI preventer with an MDI reliever at just over 200 kilograms of CO2 emissions, and the bar on the right shows an MDI-only combination of inhalers, which comes in at a whopping 439 kilograms of CO2 emissions annually. I expect that more patients would agree to changing their metered dose inhalers than they would to changing their car or their diet. They also compared English and Swedish prescribing data. In 2017, 70% of all inhalers sold in England were MDIs, compared to 13% in Sweden. This difference was largest for SABA inhalers. Applying the Swedish DPI and MDI distribution to England would result in an annual reduction of 550 kilotons of CO2 emissions. That's the equivalent of 110 return flights from London to Sydney. Interestingly, when looking at WHO data regarding asthma death rates, Sweden has half the number of deaths per 100,000 population than England. To get an idea of where we're at now, data is available on the Open Prescribing website. This graph shows how NHS Kerno CCG compares with other CCGs nationally, showing MDIs prescribed as a proportion of all inhalers. The new guideline came out in early 2020, and encouragingly, you can already see a downward trend since then. It would be great to see the red line dropping further to well below the national median before too long. You can look at your individual practices on the site to see how you are doing and to add an element of competition to incentivise you further. So we know what we need to do, but how are we going to do it? Over to you, Jill.
Thank you. So Kawita's focused a lot on the environmental impact and all those really fascinating comparisons, which are really good food for thought. I'm going to talk more about how we can use inhalers better to improve patient care. But just to back up Kawita's, I guess, pitch to be more environmentally friendly, on the left here you can see recommendations from the British Thoracic Society. And what BTS are saying is that if we're starting a new inhaler, we should really go for a DPI first. So Kawita touched on error rates with different inhalers. And if you look at data, well, lots of data sets over the last 50 years, what you'll see is generally we see this 70% error rate associated with the use of metered dose inhalers. And actually in the UK, we are prescribing the most error-prone inhaler most of the time. We know that dry powder inhalers have lower potential for error, and this 50% figure comes from a study that looked at some of the older types of DPI that we've used in the past. And I'm going to show you some more recent data in a little while. So poor inhaler use is associated with worse outcomes. And if you think about it practically, a poor inhaler technique can mean that little or none of the drug actually reaches the lungs. And if the drug doesn't get in the lungs, it doesn't work. So it's not surprising that poor inhaler technique is associated with increased exacerbations, hospital admissions, attendances at ED, courses of prednisolone and antibiotics. So there's lots of reasons to try and improve things. When I saw this data, I was quite sad, really, because I've been working in respiratory for about 25 years. So this was a systematic review by Sanchez, and what he did was he looked at lots of studies that looked at, good inhaler use. Sadly, what he found was that over 40 years, there has been no increase in the proportion of patients using inhalers really well. So if we're going to make a difference, then we've got to start to do something different. So there's a couple of studies here that represent some of the newer, more modern inhalers, some of what I call the simple inhalers. So there's data on the left for the Ellipta, and these were studies where the patient used the device after only reading the instructions in the packet. Clearly, that is not what we really want to happen. We want patients to be taught. But in this worst case scenario, in all of these sub-studies, more patients could use the Ellipta correctly after reading the instruction leaflet than a lot of the older inhalers, dry powders that we've used, like the Turbohaler, the Handyhaler, the Breezehaler, etc. Interestingly, the 50% DPI error rate, what you can see in this study, if you just eyeball across the bar there, is that most of those devices are reporting roughly a 50% error rate. And then the other study on the right is the Nexthaler, so another really simple inhaler. And what this showed was a lower number of any error, and in particular critical errors. And our critical error is an error where the patient receives little or none of the drug. So we're starting to get evidence through that suggests that the simple inhalers actually might be more user-friendly for patients. And I have got a bit of a comparison, and I think we've really got to try and engage our patients, because if you see someone on Coronation Street or on TV or anywhere using an inhaler, it's always an MDI, and in the UK it's been our go-to device, so people are often very wedded to them. But MDIs are actually over 50 years old now. And I will say to patients, we have got better technology. So I think this comparison's really helpful because none of us drive the car that we had 50 years ago. There are now modern, superior, easier to drive cars, more comfortable, more luxurious cars. Now, I chose this Toyota on purpose for this example because not only is the Toyota comfortable, modern, has lots of gadgets, this car's actually a hybrid. So it's also energy efficient. And I think this car now is available in a complete electric plug-in. So just as car technology's moved on, so has inhaler technology. And it's time that we started to embrace this to try and improve things. So in Cornwall, we have an inhaler strategy. Now, this strategy sits across both our asthma guideline, which was published in about March last year, and also the COPD guideline, which was published in March 20. So it's the same strategy, whichever disease you're treating. And we've tried to keep it really simple and really practical. So in the past, we'd give a patient the inhaler that was perhaps our favourite or the one we used. And then we try and teach the patient to breathe in the right way to use it. So our suggestion is that you actually match the device to the patient. So an easy way to do this is most patients have got a blue inhaler in the pocket, usually an MDI, is just ask them to take a puff and look how they inhale. Now, the vast majority of patients will inhale quickly and deeply for 2 to 3 seconds with an MDI, and that's actually the wrong technique. That's a critical error for an MDI. So if your patient can inhale quickly and deeply, then we suggest that you match the inhaler to them. So in most cases, that would be a dry powder inhaler. If your patient can't inhale quickly and deeply or can't hold their breath, then those patients are probably more suitable for a metered dose inhaler. And using an MDI, patients need to inhale slowly and steadily over about 4 to 5 seconds. And if you just do a little exercise, I won't do it now, but just use the timer on your phone and time how long a breath that is, you'll be quite surprised. So we're recommending that if a patient is suitable for a dry powder, that should be our first line choice, including their reliever inhaler. And if patients are unsuitable for that, then we'd give them a metered dose inhaler or soft mist for both or all devices, but we'd like you to always prescribe with a spacer. And that's because there are very few patients who can use an MDI effectively without a spacer. Really importantly, whatever role you're in, whether you're a GP, nurse, pharmacist, it's really important to check inhaler technique, particularly before escalating treatment, because we often find that treatment's escalated, but actually the problem is that the patient isn't getting the drug that they've been prescribed in the first place. And then finally, we'd like you to use combination inhalers where appropriate. So using combination inhalers where appropriate, why are we asking you to do this? Well, if we want patients to take their treatment ongoing, it helps them if we can make it simple. It also helps us because at review, we only have to check inhaler technique of 1 or 2 devices, not 3. So it probably helps with concordance, and also it helps with inhaler technique because many of our patients are on a DPI and an MDI, and not only do they have to do 2 different things to use the inhaler, in that situation you also need 2 different inhalation slides. So I think sometimes we're making things overly complicated. And as you can see from these examples, it also helps the NHS because usually it's cheaper. So the example we've got here would be often a patient with COPD who's on an ICS LABA and a separate LAMA, and obviously a SABA. Now, as they're on MDIs, we'd want the patient also to have a spacer. We're introducing a spacer really because MDIs are hard to use. So we now have triple inhalers available. And if your patient's what I call a DPI type person, then you could give them Trelegy Ellipta as the dry powder inhaler, so 3 drugs in one, and then you'd give them a dry powder for the SABA. Now, if your patient needs an MDI, then that's absolutely fine, because we have Trimbo as the option there for the triple with the SABA, but you're still making an improvement for that patient because you're reducing one inhaler. So we're trying to encourage the use of really easy inhalers because, again, it comes down to common sense. If you give patients something really, really simple to do, there is actually less room for errors. So in the green box, we've got the simple dry powder inhalers that we're recommending. In the blue box in the middle, we've got MDI and soft mist options with the all-important spacer. And then in the red box, we've got some examples of the really difficult inhalers. So these are the ones where we're asking patients to put a capsule in. These are all licensed in COPD, and I've seen these given to people with dementia, people who've had a stroke. I had one patient where it took them 12 attempts to actually fit the capsule in. We have got simpler things, and generally they're not usually any more expensive. And we've tried to help because there is an absolute myriad, and the selection of inhalers seems to be an ongoing explosion, which makes people feel as though they don't know where to start. So on the guideline, the top is an excerpt from the asthma guideline, and the bottom is an excerpt from our Cornwall COPD guideline. You can see that we've made recommendations of simple inhalers. All the devices are still available and on formulary, but we've tried to give you a starter for 10 and a steer towards simple inhalers that most patients will be able to use. And we've given you both MDI and DPI options. So I've got a case for you. This is a fairly recent case. So we now do a severe asthma clinic. It's quite an intensive multidisciplinary clinic, and patients spend about 2 hours with us. So it's a lot of, I guess, healthcare that the patient receives. And we had a chap who came along. He'd been referred by his GP, late onset asthma. He was having a course of prednisolone most months, which made the world of difference to him. And then when the course finished, he started to deteriorate again. And we could see from his bloods that he'd likely got eosinophilic asthma, which firstly responds really well to steroids, both inhaled and oral. But also these sorts of patients, if uncontrolled on standard therapy, we would be considering for a referral to Plymouth for consideration of a biologic. So this chap was on high dose ICS LABA in an MDI, no spacer, and on Spiriva hand inhaler. When I saw him to assess his inhaler technique, he was making a critical error with the MDI. And I could say, hand on heart, that that patient was getting no drug whatsoever delivered to the lungs. So the patient used his inhaler like this. So that essentially, if we can go back to the slides, that essentially really meant that from a steroid perspective, this patient's asthma was untreated. It was only being treated when he was on a course of prednisolone. And I popped this case in just to really illustrate how vital it is that we check inhaler technique, particularly if patients are having problems, because it's entirely possible that this chap's asthma will be controlled just with inhaled therapy. So it's about all of us making sure that we're doing the basics really, really well. So if we get it right, there's something in it for everyone. So for the patient, they'll get better disease management. We know that we can really improve quality of life and reduce exacerbations. That helps us because it reduces healthcare utilisation, and we are all under pressure, aren't we? Whether you work in primary care or in the hospital, it's really difficult. We can reduce the waste of medicines, and in the UK we spend £1 billion a year on inhalers, and if you think about our MDI scenario with 70% error waste, we've got a lot of room for improvement there. If the patient gets good control, then we can actually reduce the overall number of inhalers because they'll use less SABA, and if we combine. And of course, we will reduce the inhaler carbon footprint, and we'll save money across the system. So there's kind of no loser in this if we can apply some simple principles and a bit of a change of practice. We really can make a difference. So it's nice to have a good news story. So this was a clinic just after Christmas. I saw a young man who'd been admitted in December with an acute exacerbation of asthma. I have to say, not all my clinics are like this, so we have to hold on to these happy stories. So when I met this young man on the ward, he felt that his asthma was usually well controlled, but when I assessed his normal symptoms, he was needing to use his reliever every day. He woke up 2 or 3 nights a week. He couldn't really exercise particularly, but he's had asthma all his life and he just thought that was normal. So when we looked at his inhaler technique on the ward, he had an MDI no spacer. His inhaler technique wasn't the worst I've ever seen, but it wasn't great. So we optimised his treatment regime, and we started him on one of the really easy to use dry powders for both his ICS LABA and his salbutamol. So we're now trying to see patients 4 weeks after discharge from hospital, because that enables us to see how they're going on, but also make any further tweaks or actions that we need to. So when he dialed in, he was absolutely beaming, and I started off with, "How are you?" as you do, and he said, "I'm great. Actually, I've never felt this well in my entire adult life." And I think it just takes us back to that common sense practicality. If we can get the drugs in the lungs, they usually work. And I think we didn't do any major magic with this young man. We just gave him an inhaler that he could use to get the drugs in his lungs, and he was getting the benefit of that. So that made my day. So going back to our green theme, so making greener inhaler choices doesn't necessarily mean moving to DPI, although where we can, and I think in many, many patients, a DPI will be suitable. We can also make a difference by making sure that every patient has an inhaler that they can use that's right for them and that they will use. So we need to really engage patients as part of this process, because if a patient doesn't like their inhaler, they won't use it. But using combination devices and using short actings with dose counters will also help to reduce the number of inhalers each patient uses. So if we get it right, we'll get more drug in the lungs, so that would be a great start. Hopefully the patient will then get better disease control and need fewer reliever inhalers, and will also reduce healthcare utilisation. And as Kawita said earlier, all these examples of that I've put in the boxes below also have an associated carbon footprint. So it's much wider than just the inhaler. It's around getting it right for the patient, achieving good control. So I live and breathe inhalers, I'm sad to say. I do sometimes say if I was on Mastermind, it'd be my specialist subject. And I know that many of you won't be in the same boat, but it is really quick and easy once you know how. So I wanted to go through basic steps of inhaler use, and just to point out that not all errors are device related. So there will always be something that you need to do to prepare an inhaler, and I'm going to use an MDI as my example here. So with an MDI, you need to shake it and remove the lid. Posture is not device specific. The best position to take an inhaler in is standing, so that you can expand your lungs. If you're not standing, then sitting upright with your feet on the floor, but also a slight up tilt of the chin just helps to straighten the airway. And I always explain to patients why we're asking them to do these steps, because I think if they understand that, then they're more likely to remember to do it. So exhale so that you've emptied your lungs and you can take a bigger breath in. The inhalation is device specific, and with a metered dose inhaler, we want a long, slow, gentle breath over 4 to 5 seconds. And with a dry powder, it's a more forceful breath. I sometimes say strong and long, because you do still want them breathing in for about 2 to 3 seconds, but more forcefully. Then we want the patient to hold the breath, because we don't want them to just breathe all the drug out. And I say for a count of 5 to 10. And if your patient can't hold the breath, then probably MDI with spacer using tidal breathing would be the best option for them. And then with a metered dose inhaler, there is lots that can go wrong. So first of all, once you've used an MDI, it needs 1 minute before it will emit another dose. So those patients who you see double puffing, or who've put 10 puffs in an emergency one after the other, will only have actually got one dose. So waiting for 1 minute, and then with an MDI you have to shake it again. If you don't shake an MDI, you actually only get the propellant, not the drug. So that's another common critical error with an MDI. So with MDIs, you have to wait, then repeat. Dry powder inhalers don't require you to wait before your next dose. If your patient's on an inhaled steroid, we'd be advising them to rinse and gargle. And I've just put and replace cap, because there have been some reports of patients inhaling fluff out of the handbag, or bumblebees and spiders. So just putting the top on is important. So that sounded long-winded, but actually it isn't. So I'm just going to go off slides now and just try and quickly show you with an MDI. Okay, so with an MDI, you want your patient to prepare, so they're going to shake the device, remove the cap. Posture, so sitting up straight, chin slightly up. We want them to exhale away from the inhaler. And then obviously wait and repeat. Now, have you ever seen a patient inhale an MDI like that? Because I have to say I rarely have. And I suppose it just illustrates why these devices are not really ideal. It's not what most of our patients want to do. So I've got Kawita now to be my patient. And I'm going to talk through Kawita using one of the really simple dry powder inhalers. Hello, Kawita. Thank you for coming to my clinic this afternoon. Nice to meet you. So I'm going to just quickly try and teach you how to use this new inhaler. So your new inhaler contains a powder. So to prepare the inhaler, you need to open the top. So slide from the side till you hear a click. Lovely. So if you could just make sure that you're sitting up nice and straight with your chin up a little bit. And I want you to exhale away from the inhaler first. Then pop the inhaler in your mouth and take a nice strong breath in for about 2 to 3 seconds. You'll hear the device click, and that means it's actuated. And then if you can hold your breath for a count of 5 to 10. And then to take your second dose, you just need to repeat those steps. Thank you. How was that for you?
Great, thank you, Jill.
So, I want to hand over to Kawita now, because I eat, sleep and breathe inhalers, as I said before. I know that isn't real life for many of you. So Kawita, it would be really great to hear how you've gone about this in your GP role and in your practice.
Thanks very much, Jill. So, yeah, I read this article back in 2019 and started about trying to take action. Thankfully, Jill was already working on the COPD guideline, and this would be shortly followed by the asthma guideline, both of which aim to optimise patient care and in doing so prioritise greener inhalers. To be honest, with practice nurses bearing the brunt of routine asthma and COPD care, I had to go back to basics, which I don't think is unusual for a GP. I met with a couple of colleagues and we came up with a plan of how to get started, then ran a few searches to identify some patients. As the COPD guideline came out first, we started by finding all COPD patients who were on both MDIs and DPIs and aimed to combine inhalers, preferably choosing DPIs. If we'd had started with asthmatics, I think I would have started on those high SABA users, as they are clearly not well controlled and would have the most to gain by optimisation of their medication. So when I am seeing a patient to optimise their inhalers, I follow a 3-step process. So step 1, I look at what the patient is on now. For this, I very much still rely on the inhaler ID guide. Step 2, I work out what should the patient be on. So for this, I look at the local guidelines, which look like this, and they're both available on the Cornwall Joint Formulary. I then, for COPD, I will check for number of exacerbations in the last year and look for a baseline eosinophil level. For asthma, I will check their SABA use and again look for exacerbations in the last year. I will look at their technique to see what type of inhaler they'll be suited to, and I would do a subjective assessment score, such as the CAT, the CAT score for COPD, or the ACT score for asthma. And then step 3, I would make the change. So I would recommend a change of inhalers involving the patient as I go. I would advise regarding technique, ideally with the patient, but I would also signpost to the Asthma UK and Right Breathe inhaler videos. I would make use of whistles and placebo devices. I would encourage self-management plan and safety net, and I would arrange a review, ideally repeating the CAT or ACT scores at 2 months. So patients have been very responsive to the changes made, and I've had a lot of very positive feedback, including significant improvements to quality of life. A few have not got on with a change to a dry powder inhaler, but have been optimised on MDI combination inhalers with spacers. And as already mentioned, I think it's important to remember that combining inhalers and optimising drug delivery, even if you stick with an MDI, will lead to carbon emission savings and financial savings and reduce burden on the NHS. So let's watch a consultation in practice.
Oh, next patient COPD review, please. Respiratory nurse not available. Why does it have to be me? Oh, hello.
Hello, doctor.
Hello, come on in. Have a seat.
Oh, just coming up those few stairs. Oh, you can see. But just get me breath in. So I got all of these inhalers in here. None of them doing anything. I got Let me show you a minute. Hold on a minute. Let me show you what I got here. Let me show you. Oh, okay. They're in here somewhere. This is what I call my bingo bag. I take the bingo. Oh, there we go. That's the one I take. Is that the one I take? There, that's the one. There, see? These here, look, I take them. There, I take all of them. Look at me. None of them doing anything. None of them. All of this, nothing. I get given every so often, you put me on steroidy things. Well, they give me nightmares, in fairness, nightmares. And then you also, you prescribe or subscribe or whatever you call it. You give me antibiotics. Well, they're hideous, horrible things. And none of them doing any good. I need some help here, doctor. I can't carry on like this. I can't get up the bingo steps without coughing for the first 3 rounds, and they're going to ask me to leave. I can't carry on like this. Anyway, sorry, there we are.
I'm sorry to hear this, Barbara.
Babs, call me Babs.
Babs. Could you tell me which one of these inhalers which ones you're using at the moment?
Yeah. Well, at the minute I use this one here.
Okay.
This one.
Yeah.
Because apparently that's the. I think that's the most effective.
Oh right. Okay. Okay. So that's your Relvar inhaler. And can you show me how you're using it?
Oh,
Could you give me a demonstration?
Yeah, absolutely. Absolutely. I'll take my mask off if that's all right.
Absolutely.
Here we go. Oh, take the cap off. Go like that. I'll put some there, look. Because I can breathe on that, see, but later on, see. Go like that.
Okay.
Ain't working.
So, at the moment, shall I take your other inhalers that you're using?
Oh, hang on a minute, let me just...
Oh,
sorry. There we go, look there.
So, you were on these. Look at your inhaler identification guide to work out what drugs the patient is taking. So, looking at the inhaler identification guide, you're taking a short-acting beta agonist in a metered dose inhaler form, an inhaled corticosteroid in a metered dose inhaler form, and a long-acting muscarinic antagonist in a dry powder inhaler form. Do you have a spacer?
Oh, I do have one, my dear, but see this bag here? It's really big, and by the time I get all of me important stuff in, I can't fit a spacer in, so I had to ditch it, and to be honest, it didn't work anyway.
Okay, so you're not using a spacer?
No, I can't fit it in my bag.
Okay. Well, I still think there's something that we can do to change these inhalers around to make them work better for you.
But what?
Familiarise yourself with the COPD inhaler prescribing guidelines. So looking at the inhaler guideline, I think that we should change your inhalers around. Because you've told me that you've had 3 exacerbations, and I've looked at your notes and that confirms you've had 3 flare-ups in the last year needing the steroids and antibiotics. We should follow the right-hand arm of the COPD guideline, which should suggest that you should be taking a long-acting version of your blue inhaler, as well as an inhaled steroid. These 2 inhalers can be combined into one inhaler, and that will make them work better for you. Can you show me again how you use your blue inhaler? This time without spraying around the room and on your body, just using it into your mouth.
Oh, yeah, I can do that. I don't tend to do that because it hurts to my throat like now. Right, here we go, right, ready?
Can the patient inhale quickly and deeply? If so, they can take a dry powder inhaler. If not, they would be best suited to a metered dose inhaler with a spacer. Ideally for this we would use an in-check device, but we are not currently using those because of COVID restrictions. In the meantime, this resistance range chart may help. So you do have a good, firm, forceful in-breath.
I got good lungs.
So I think you would be suited to a dry powder inhaler rather than a spray inhaler or a metered dose inhaler. The spray inhalers, such as those ones, have a gas in them, a propellant, which pushes the drug out of the device and into your lungs or into your mouth. But if you then do a forceful in-breath, a lot of the drug will just end up in your throat and won't get down into your lungs. And this might be why your inhalers aren't working for you. Whereas a dry powder inhaler doesn't have that gas in them, doesn't have the propellant, so you suck the drug into your lungs. And I think that will work well for you.
Oh, okay. So what you're saying then is, this one isn't very good for me.
No, I don't think it's working.
Dry powder inhaler, because of how I breathe, which, you know, you can see I've got a strong breath there, is the best thing to get to my lungs if I use it.
Absolutely. In addition, the dry powder inhalers, because they don't have the gas in them, they're much better for the environment. Okay, so what I'll do is I'm going to change your inhalers over.
Oh, okay.
So I'm going to give you 2 dry powder inhalers today, and I'll do the prescription for you. I want to show you how to use them. So with your maintenance or preventer inhaler, which replaces your brown spray inhaler and the other dry powder inhaler that you have, to use them, you open up the lever until you hear a click. You then breathe out, put the device to your mouth, and breathe in with that hard, fast breath that you just showed me. You then hold your breath for 5 to 10 seconds until you feel comfortable, and then you let your breath go out slowly. And instead of your spray blue inhaler that you've been showing me how you use it, you'll have a different type which has the same drug in them but just none of the gas. And for this one, you release the powder into the device by clicking the device down, and then you put your mouth around the end piece, and again that same strong breath, and hold for 5 to 10 seconds. And hopefully this will make a difference to you. You don't need a spacer for these. It's, 2 of your inhalers are combined into one, and the blue one is the one that you'll have every time you head off to the bingo. So I'll see you back in a month for a review, and I would like you to bring your inhalers with you so that you can show me how you're using them. But if you do have any problems before then, please come back sooner.
Fantastic. Okay, well that's lovely. Thank you for that. That's really appreciated. Because you can see I'm struggling with my breath and everything. And of course, like I said, I'm going to get banned from bingo if I carry on coughing and spluttering and what have you. But no, that's lovely. Thank you. Thank you, Doctor. I'll see you in a month's time.
Absolutely.
And I'll get my new prescription. Okay. Thank you ever so much.
Thank you. Nice to see you.
Well, thank God she didn't mention my smoking.
Oh, and Barbara, remember the single most the single most important thing that you can do to help your lungs is to stop smoking.
Okay. Thank you. Thank you.
Okay. That's it. Don't forget the fundamentals of COPD care. Trying to get the patient to stop smoking, encouraging an exercise program, considering mucolytics, optimizing management of other comorbidities, recommending appropriate vaccinations, and considering referral for dietitian input for low or high BMI.
So let's quickly go through what else is coming up in Cornwall and what we're doing down here to complement what you clinical guys are doing. So we've been working with the council. So understanding that down here in Cornwall, we're headed for warmer, wetter winters. Those suffering from fuel poverty are really going to find this time quite challenging. So what we've done is we've worked with the council and we've been targeting patients over 65 years of age so that we can link them up with the Warmer Homes grant. So that's basically tapping into the grant that's already available, and the council go out and do maintenance to the patient's homes, and that could be fixing a radiator, it could be giving them a blanket to get them through the winter, or it could be installing full central heating. But either way, it's preparing and putting in elements of prevention, knowing that a damp home creates mold, you breathe in mold, you end up as an admission, we cure you, you come back, the circle goes on and on and on. So the second element we've been working on is we've invested in our COPD nurses. So this is Jill's team. This is really just so that we're now able to inreach into ED and into our wards to tackle the problem that we know when patients aren't given the full techniques that they need. So this has been going on now for some time, probably about 3 months, both going really well. And we're also really proud of it down here in Cornwall, that it's something that we got going as part of an innovation. So good news all round, and thank you, Jill, very much for your team in supporting that. So I think now it's probably time that we went to questions, if we have any. Peter?
Yes, so our first question says, I was on a DPI for years, but my GP explained that due to additional costs, they were going to change me to an MDI. How are you going to encourage GPs and pharmacists to change their mindset and move away from the budget issue? Thanks. This is a really informative webinar and gives us much to think about.
Shall I pick that one up? So historically, but going back quite a long time now, dry powder inhalers were significantly more expensive than metered dose inhalers, but that actually is no longer the case. So I'm not saying there aren't any differentiators or cheaper options, but in general, you can get an equivalent DPI for the same cost. So if cost the issue, I think as the newer inhalers have come in, they've been priced really competitively and realistically. So I think that barrier has now gone from my perspective. I don't know if Kawita's got anything to add.
Yeah, I would agree. I mean, if some brands, for example, Foster, it's exactly the same cost for the MDI and for the DPI. And certainly there has been research done. I mentioned a paper by Wilkinson and others in 2009 regarding the costs specifically. And yes, some brands are more expensive. Some brands of DPI are more expensive. But if you choose a less expensive brand, then certainly those the actual financial cost of the device is definitely competitive when it comes to comparing the MDIs and DPIs.
Thanks very much. Next question. As a pharmacist, how can we support the correct inhaler techniques for patients? Do you want to go with that, Kawita?
I was thinking that would be perfect for Jill.
Oh, let's go with Jill then.
Well, I think certainly, so where I work, I spoke to the pharmacy that's attached to our practice, and because I was trawling the surgery for devices and placebo devices that I could use for this webinar, and actually they do have training devices in the pharmacy, and so when I'm speaking to patients to advise them regarding their inhaler, unlike in the video, the clip that we've just seen, I obviously don't have the actual device with me. I explain the technique, and then I'll signpost them to the Right Breathe and Asthma UK websites, and then I usually say to the patients, so we can further ask the pharmacist before you leave the surgery, or you leave the pharmacy, to show you how to use the device. So certainly, if more support is needed, then by the pharmacist to deliver this training, then I think it would be really good for us to get involved and work together. Jill, have you got anything further to add?
I'd agree. I think a team approach is really important because, like with anything you do every day, even if you go to driving, we all fall into bad habits. So the inhaler misuse and errors is so prevalent that actually, if all of us take every opportunity that we've got to check and refine, then that's all going to be additive and just gives the patient more support. So I think if someone's picking up a prescription and they're happy to show you how they use their inhaler, or you to show them if it's a new device, all of those interactions are extremely valuable.
Thanks, Jill. We've had another comment to say. I have to say, I've recently been switched to a DPI from an MDI inhaler as my asthma was uncontrolled. The difference has been life-changing. I've not had to use my Ventolin inhaler since, and even managed to walk up a mountain the other week without using it, which is really positive. Probably another question for you, Kawita. How do you find the time to check on inhaler techniques in a GP practice?
Well, it doesn't take that long, because I just get them to show me a breath in. I mean, if a patient's come in for review, sometimes they'll bring an inhaler, often they won't. But I will just ask them to show me how they would breathe on their inhaler. And so really it only takes a few seconds, and so I will then be able to use that. I think previously there were in-check devices available, but by the time I became aware of those devices, COVID hit and we weren't able to use them. So over the course of me doing a lot of inhaler work, I haven't really had had those devices to use. So it has just been watching them within a few seconds as they breathe, and then recommending them. I mean, essentially the other thing is as we know that 70% will make an error with an MDI, I think that, we're GPs, we're used to balancing risk, and I think actually it's just a case of giving it a go. They're already probably not getting the right amount of drug into their lung anyway, so I think recommending the change, explaining and advising, and then encouraging them to come back if they feel worse. And actually there's been relatively few who've had to come back. So
that's great, thank you. So then we've just had a few comments about thank you for the excellent webinar, and doctor-patient video, very educational. And then a few questions about whether it will be available, or a copy of this will be available after the webinar. And I think we're safe to say that a recording will be published on RCHT's YouTube channel as soon as we can, which should hopefully be by the end of the day. And that's it for all the questions.
Okay, so thank you all. All that's left for me to say is thank you for watching, and from now it's goodbye from Cornwall.